So let's go ahead and get started because I know we have a meeting in this room after Prachi's done, so I want to make sure we give her as much time as she needs. Today's Grand Round speaker is Prachi Raut. Prachi is currently a surgical pathology fellow in our program, and prior to that was a resident in our program. She comes to us from medical school in India, and she will be talking today on spindle cell lesions of the breast.
Thank you, Sarah. Good morning, everyone. So the topic is a review of spindle cell lesions of the breast. I have no financial conflicts to disclose. The objectives of my talk are describe the histomorphology of the spindle cell lesions of the breast, discuss the role of immunohistochemistry and the diagnostic algorithm for the spindle cell lesions of the breast, and recognize the limitations that are encountered on needle core biopsy. So to begin with the introduction, the spindle cell lesions of the breast can be reactive, benign, malignant, or metastatic. They share the overlapping morphologic, immunohistochemical, clinico-radiologic characteristics, and further with these days, every breast lesion being diagnosed with a core biopsy, it provides a limited tissue sample for pathologists. The differential diagnosis of spindle cell lesions is very wide, and the treatment varies significantly depending on the diagnosis. Further, each of the spindle cell lesion has a wide morphologic spectrum of its own. So most of these lesions are fibroblastic and myofibroblastic. Many of the fibrous lesions that occur at the other body sites also occur in the breast, but there are some lesions that are unique to the breast. The myofibroblast is the ubiquitous constituent of all these lesions, and that's the reason they share all these morphologic characteristics, including even the ultrastructural overlap. So the key components to evaluate are composition of cellular proliferation, whether it's spindle cell or epithelial cell, or both. If it's mixed, are they intimately mixed, or they exist as two distinct components? Presence or absence of cytomorphologic atypia. The important thing is absence of atypia does not equate to a benign lesion. The growth pattern that includes tumor border, whether it's well circumscribed or infiltrating. Mitotic activity, associated adjacent admixed cells and or tissues, and obviously the clinical and radiologic features. The sample size is often inversely related to the breadth of the differential diagnosis because there is always a possibility of the core biopsy not containing all the key components of these lesions. The major differential diagnosis based on the cytologic atypia, they are divided depending on whether the spindle cells are bland or atypical. These are some of these, but not all of them. So bland spindle cell lesions can be scar, fibromatosis, myofibroblastoma, a fascicular type of pseudo-angiomatosis-stromal hyperplasia that would be referred as an PASH, Adenomyoepithelioma, spindle cell metaplastic carcinoma is a big category, and the atypical spindle cells lesions can be metaplastic carcinomas, which are high grade, malignant phylloides, nodular fasciitis, primary sarcomas of the breast, metastatic sarcomas, and metastatic spindle cell carcinomas, and metastatic melanoma. The simplified approach to diagnosis is to evaluate two principal components of the lesion, spindle cells and epithelial cells, if they are. The spindle cells can be bland or pleomorphic, and epithelial cells can be benign or malignant. And based on this, they can be divided into four groups. The biphasic lesion are where there are predominantly spindle cells and benign ductal component, which includes fibroepithelial lesion like phylloides and fibroadenoma, but also other lesions like PASH, hematoma, adenomyoepithelioma. Second is biphasic lesions with predominance of spindle cells with malignant ductal component. The main differential diagnosis here is metaplastic carcinoma. Monophasic lesions, which constitutes purely pleomorphic spindle cells, is mostly like the monophasic high-grade metaplastic carcinomas, but this also includes other sarcomas like Angiosarcoma, MFH, and other high-grade sarcomas. And the fourth category is monophasic lesions that have bland spindle cells only. These include fibromatosis-like metaplastic carcinoma, and unusual conditions to keep in mind like DFSP that can occur in skin, and so it can occur in the breast skin. The important thing is spindle cell lesions are not necessarily the pure stromal lesions, and it's always crucial to search for epithelial component, and that could completely alter the diagnosis. So the biggest is spindle cell metaplastic carcinoma. Any spindle cell lesion of the breast, this should be the first differential diagnosis, and that should be excluded. They are uncommon and they account for less than 1% of the invasive carcinoma. They are essentially epithelial in origin. The variable portion of the glandular epithelial cells undergoes transformation to alternate cell type. This cell type could be either epithelial but non-glandular like squamous, or mesenchymal, which could be spindle cell type, or heterologous element, which could be chondroid, osseous, or myoid. There is no uniform classification scheme for metaplastic carcinoma. Now, the clinical presentation and pathology of this metaplastic carcinoma is similar to patient with who have like invasive carcinoma of no specific type in terms of the age of presentation, the manner in which they present, and the location within the breast in which they arise. Mammographic appearance is not specific. They are usually fairly circumscribed and non-calcified. That makes them appear like benign. And there are some authors which suggested that when they studied this metaplastic carcinoma, the lesions which had circumscribed and speculated margin corresponded to the mesenchymal spindle cell and the invasive epithelial component respectively. Gross, these lesions can be well circumscribed, can have indistinct or irregular borders. Relatively, they are relatively large in size compared to the invasive carcinoma of non-specific type when they are detected. So 2012 WHO descriptive classification of this lesion classifies this as morphologically as squamous cell carcinoma, metaplastic carcinoma with mesenchymal differentiation, low-grade adenosquamous, spindle cell carcinomas, also called sarcomatoid, fibromatosis-like metaplastic carcinoma, which is also called a low-grade, and myoepithelial carcinoma. The metaplastic carcinomas are usually ER, PR, and HER2 negative ones. So the morphology, they may consist only of spindle cells or spindle cells admixed with epithelial component, which could be glandular or squamous. Foci of overt epithelial differentiation in the form of invasive carcinoma, DCIS or ADH are clues to correct diagnosis. The appearance of the spindle cell varies. They can range from bland, just looking like fibromatosis, to highly pleomorphic. And the arrangement can range from anything like fascicular, fasciitis-like, storiform, to haphazard arrangement. The mitosis is variable and the borders are usually infiltrative that entraps the mammary stroma, ducts, lobules, and invades the adjacent adipose tissue in like a lace-like pattern. You can also see a heterologous element, especially the chondroid or osseous, and the diagnosis requires the use of panel of cytokeratin immunostains. The lymph node metastasis is rare, and there is a discussion whether the sentinel node biopsy should be done in the metaplastic carcinomas when you know the diagnosis. Usually the panel of antibodies against the low molecular and high molecular weight cytokeratins are used. Usually the broad spectrum for high molecular weight are positive. And the working group recommends unequivocal expression of cytokeratin or P63 in any proportion of spindle cell for diagnosis. But negative IHC does not exclude the diagnosis. EMA can be variably focally positive, and usually the panel, when they say for cytokeratin antibodies, is usually a broad spectrum cytokeratin like anti-MNF116, high molecular weight cytokeratin, that is 34 beta E12, CAM 5.2, cytokeratin 714, and basal cytokeratin CK5 and 6. These cells also express P63, vimentin, SMA, and MSA. So the expression of these basal markers, which are CK5-6, P63, actins, and other markers which are basal epithelial or myoepithelial, indicates the basal epithelial and myoepithelial nature of these tumors that blurs the distinction between the spindle cell carcinomas and actually what were diagnosed before as malignant myoepitheliomas or myoepithelial carcinomas. And the recent gene expression profiling studies have expressed that some of these metaplastic carcinomas belong to basal epithelial-like group, and some of them to the epithelial mesenchymal transition group, which is also called like a low Claudine group. So this is a figure showing the spindle cell carcinoma, commonly seen as a highly cellular lesion. You can see the interlacing fascicles of highly atypical spindle cell. Just looks like an fibrosarcoma or just a sarcoma with numerous mitosis. There is no evidence of epithelial differentiation here. This is the figure that shows the atypical mitosis and the other numerous normal mitosis. The spindle cell, this is a spindle cell carcinoma with foci of squamous differentiation. There is a variant of spindle cell which has a pseudovascular spaces, and then the differential there is usually like angiosarcoma. This is easy. Here there are foci of overt epithelial differentiation, and the diagnosis then becomes straightforward. The p63 immunostain is positive here in most of the tumor nuclei. The p63 immunostain can be a pitfall. Initially it was thought it's very specific for a metaplastic carcinoma, but there are recent studies that show the presence of p63, including p40, and also the cytokeratins like AE13, CAM5.2, in the stromal cells of phylloides tumors, and but they are usually seen in malignant phylloides and not in the benign and borderline. So there are some other papers because the p63 is not now specific, there are other stains that are studied like SOC stain and GATA3, which are more specific for metaplastic carcinoma, which are triple negative, and these are not positive in the malignant phylloides, because the stromal component of malignant phylloides is the most important differential in the metaplastic carcinoma, and these are the two big differentials of spindle cell lesions of the breast. So this is a figure that shows only few cells that are cytokeratin positive, but as long as they are unequivocal, any amount is okay. This figure shows the spindle cells that are infiltrating into the adipose tissue in an irregular pattern. That's called lace-like pattern. So fibromatosis-like metaplastic carcinoma. This is very important because it can be very treacherous. It's a very low-grade lesion that can be confused with fibromatosis or scar. It can arise de novo or can arise from the pre-existing papillary or a sclerosing lesion. They're usually just like metaplastic carcinoma, well circumscribed appearance. They have low cellularity, as you can see here, abundant stromal collagen and bland nuclei that doesn't have any of the features to suggest malignancy. But that should always be kept in the back of mind. And this is the same figure that shows these tumor nuclei are positive for CK5 and 6. The differential diagnosis is malignant phylloides, radial scar or a complex sclerosing lesion with abundant spindle cell component, fibromatosis, especially the low-grade one, and the primary soft tissue sarcomas. In fact, the differential, any spindle cell lesion, the differential is metaplastic carcinoma because they are so heterogeneous in appearance, from bland to highly malignant. The next is biopsy site change or scar. So this can be a differential in a lot of the things which are low grade. The histological findings vary with the age of the scar. The first week usually there is more of a granulation tissue, and if it's very exuberant it can be confused with a vascular lesion. In the second week there is more deposition of collagen and the wound contracts, and it looks more like a fibrosis scar. So the differential here is mostly fibromatosis, low grade lesion, and a spindle cell carcinoma of fibromatosis type. So if there is a differential of fibromatosis, it's usually good to have a history, whether there was a prior biopsy, and if yes, what was the time since procedure, because if it has been a while, then it can just look like fibromatosis. Going on fibromatosis, there are two types of fibromatosis in the breast. There is a primary mammary type and usual garden variety that occurs any other body site, which is like a muscular aponeurotic fibromatosis that secondary involves the breast. And it's an infiltrative lesion, it's locally aggressive, and it's the proliferation of fibroblast and myofibroblast. Since it's so infiltrative clinically and radiographically, it may be mistaken for carcinoma because it's a gray-white firm stellate lesion. Microscopically, it shows bland spindle cells in broad sweeping fascicles, and that infiltrates the adjacent tissue, and it surrounds and entraps the mammary ducts and lobules at the edge of the lesion. Most important is a nuclear staining of beta-catenin, and these lesions should undergo wide local excision to prevent local recurrences because of their markedly infiltrative pattern. This shows the long, broad, sweeping fascicles that are infiltrating the mammary stroma and adipose tissue, and they are entrapping these mammary ducts and lobules. This is the high power view that shows these cells are uniform, elongated tapering nuclei, and they have indistinct cell borders. This is so the cellularity of this lesion can vary. Most of the time, the lesion is hypocellular at the center and more cellular at the periphery. This is a paucicellular spindle cell lesion, fibromatosis, which has an abundant collagen. And there are lymphoid infiltrates at the periphery, and you can see it's infiltrating into the adjacent breast parenchyma. This is the low point, this is the high. So these lymphoid aggregates are present in fibromatosis in approximately half of the cases. The nuclear staining of the tumor cells for beta-catenin is very important. Most of these cases are sporadic in the breast, but they can also occur as a part of syndrome, which is like a familial adenomatous polyposis, hereditary desmoid syndrome, or Gardner syndrome. They are positive for muscle-specific actin and smooth muscle actin. They can have focal S100 and desmin. The beta-catenin is positive in 70 to 75% of the cases. The beta-catenin, so all of these lesions have an immunohistochemical pitfall. So beta-catenin can be positive in solitary fibrous tumor of the breast. There are also some studies that shows beta-catenin positivity in the stromal cells of phylloides and metaplastic carcinoma. But unlike fibromatosis, the staining is focal, and it's weak to moderate. Unlike in fibromatosis, you usually see a diffuse and staining most of the tumor cells. So, and in other entities, usually the studies indicate that it was less than 30% of the overall tumor nuclei. Differential diagnosis: scar, nodular fasciitis, metaplastic carcinoma, and sarcoma. Recurrence rate is up to 27%. So that's why they need a wide local excision. And this recurrent rate of fibromatosis is similar as the recurrence rate of fibromatosis at other site. And there is this theory of desmoid tumors or fibromatosis in abdominal wall being hormonally active, like they respond to estrogen. There is some study which shows a weak association. They can be. So the next lesion is myofibroblastoma. So these are usually confused with fibroadenoma because they are firm, solitary, mobile, well-circumscribed lesion. Initially, they were thought to be more common in men, but now with the screening, they are shown to be equally common in women, but in the postmenopausal, it's more common. And they are circumscribed but not encapsulated, and they push the breast parenchyma apart so that they get a pseudocapsule. Morphologically, it's composed of the short fascicles of uniform spindle cells that have oval nuclei, and there are thick bands of hyalinized collagen in between. They call it a ropey collagen, which is very characteristic. Other important thing is they have an admixed fat, mast cells, and patchy lymphoid infiltrate. This lesion has a lot of variants that makes the diagnosis difficult. Like there is a collagenized variant, cellular, infiltrative, myxoid, deciduoid, lipomatous, atypical, and epithelioid. This needs special mention because it can mimic an invasive lobular carcinoma. So this is the low power view of the myofibroblastoma. You can see a circumscribed border, and then a patchy lymphoid infiltrate, adipose tissue, and then the bland spindle cells and ropey collagen. This is the high power view that shows small fascicles and this characteristic ropey collagen. Collagenized variant is, there is more collagen compared to cells. As compared to this figure, it has more collagen. So there is paucity of spindle cells and there are a lot more collagen. Cellular variant, on the other hand, has more of the spindle cells compared to the stromal component. Epithelioid variant are like, it has epithelioid myofibroblast, and they are arranged in the nest and cords in the dense collagen, and that makes them resemble like an invasive lobular carcinoma, like a small cells and in the background of dense collagen. The pitfall is this myofibroblastomas show strong nuclear positivity of ER, and so if you're thinking of invasive lobular and you do ER, you feel like, oh, this is a cancer. But some of the things to keep in mind are invasive lobular are usually not well circumscribed, so it's a clinical radiologic correlation. Then the myofibroblastomas are pushing the breast parenchyma more away instead of entrapping them like invasive lobular carcinoma would have it. And you can always do cytokeratin when in doubt and CD34 because the myofibroblastoma would be cells would be cytokeratin negative and positive for CD34. So this is a CD34 immunostain that shows the positivity. Differential diagnosis of myofibroblastoma it's more like a metaplastic. It's everything. It resembles to reactive and benign spindle cells, lesions like nodular fasciitis, solitary fibrous tumor. Further, it shares that CD34 positivity, but SFTs would be negative for desmin. Spindle cell lipoma needs some mention because this is a lesion which is in the differential diagnosis of myofibroblastoma, and they also share a same chromosomal aberration of loss of 13q and 16q. So somehow they are related, and spindle cell lipomas are CD34 positive, just like myofibroblastoma, but they would be again desmin negative. They can resemble peripheral nerve sheath tumor, any smooth muscle tumor, and fascicular PASH. Spindle cell sarcomas and metaplastic carcinoma, especially the infiltrative variant of myofibroblastoma, can look like a metaplastic carcinoma, and the epithelioid variant, which is a mimicker of invasive lobular carcinoma. The said majority are CD34 and desmin positive, variably SMA positive, hormone receptors negative, including ER, PR, and androgen receptors. There are no studies of recurrences, and local excision is adequate. There is a atypical myofibroblastoma when there is a focally increased ATPI and mitosis, but they have never recurred. Nodular fasciitis. It's a rapidly growing mass, just like nodular fasciitis at any other body site. It's common in the middle-aged people. It's a well circumscribed but unencapsulated lesion. The cellularity varies. It may be highly cellular, but the older lesions can be very paucicellular. The morphology is there. It's composed of plump spindle cells that have characteristic they call tissue culture appearance and having a wispy cytoplasm, and that grows in the short fascicles and whorls. Mitotic figures can be numerous, and the stroma is myxoid with extravasated RBCs and patchy lymphoid aggregates. The lesions which are regressing show variable collagenization. This figure highlights the myxoid stroma, and then this characteristic they call tissue culture fibroblast, myofibroblast, extravasated erythrocytes, and scattered lymphoid aggregate. It's the high power view showing that tissue culture appearance and vesicular nuclei, prominent nucleoli, and mitosis. Mitosis can be numerous, and that can be a pitfall. These lesions can disappear by their own, like in 4 or 5 months, but in breast, something which is rapidly growing looks like a malignancy. It usually undergoes biopsy and then excision. They are positive for MSA and SMA. Focally can show desmin, and differential diagnosis is sarcoma, metaplastic carcinoma, and fibromatosis. Especially when the mitosis are very high, you can think of sarcoma, and as older they grow, they have more collagen, and you can think of fibromatosis. They share overlapping immunoprofile with myofibroblastic and myogenic lesions like this MSA and SMA and desmin positive, and being high mitotically active might get confused for leiomyosarcoma on the biopsy. The next is adenomyoepithelioma. This is a rare lesion, and it usually presents as a palpable mass in patients who are more than 50 years. Crosslet has a multinodular lobulated lesion which is composed of both epithelial and myoepithelial elements. Usually both are like in equal proportion. There is an other end where there could be more prominent myoepithelial cells, and it's called myoepithelioma. Rosen describes the 3 variants of adenomyoepithelioma. The first is a spindle cell type where there are predominantly myoepithelial cells in a spindle cell appearance. Tubular is where there are like tubules of epithelial cells and proliferation of myofibroblasts, and lobulated is extensive proliferation of myofibroblasts that compresses the epithelial component that it's almost not very distinct. It's a benign lesion and it's adequately treated by complete local excision. This is the spindle cell variant. You can see the proliferation of spindle cells. These are all myoepithelial, and then these scattered among these glandular component. Hematoma. It's an interesting differential. It's always in the differential, but you rarely see this diagnosis. The main differential is fibroadenoma. It presents as a discrete nodule. Some lesions can have characteristic radiolucent halo, but not all of those. They have a varying amounts of mammary ducts, lobules, collagenous stroma, and adipose tissue. So the same component as the breast parenchyma. And these components can be regularly arranged, or they can have an haphazard arrangement. And so if there is more of a stroma, it looks just like a normal breast. If there is more of an adipose tissue, it would resemble to lipoma. They also have the interlobular fibrosis, can have encapsulated fat, and it's common to find PASH-like changes, pseudoangiometastroma hyperplasia-like changes in the hematoma. Some of these lesions can have smooth muscle differentiation. These are called myoid hematomas. They also can have chondroid islands, and then they are called chondrolipoma. The differentiation from fibroadenoma on a core biopsy can be difficult, and even making the diagnosis unless you have everything out. So this figure shows the well circumscribed lesion, and then it's just look like a normal breast of ducts, lobules, adipocytes, but there is a haphazard arrangement. Pseudoangiometastroma hyperplasia, or PASH. It's a myofibroblastic proliferation that simulates vascular lesions. It's a very common incidental finding. There was one study which showed almost like 23% of the breast biopsies have PASH. And it can be seen in associated with benign and malignant lesions like carcinoma, fibroadenoma, phylloides, hematoma. Sometimes they can present as a palpable or mammographic mass, then they are referred as a PASH tumor. So microscopically, it's like a complex intraanastomosing slit-like spaces that are lined by a single layer of flat spindle cells in the background of dense hyalinized collagen. Since these are myofibroblasts, they're positive for CD34, desmin, and SMA. The main differential of a PASH is an Angiosarcoma, which is well differentiated, and myofibroblastoma. The pitfall, IHC pitfall here is CD34, which can be positive in Angiosarcoma, but 31 would be negative in PASH, factor 8 would be negative, and ERG would be negative in PASH. Sometimes the PASH myofibroblast can aggregate into fascicles, and that simulates myofibroblastoma, which shows that some authors suggest that the PASH and myofibroblastoma are the two ends of the spectrum of the myofibroblastic lesion. They are common in premenopausal women, so I don't know how it is that myofibroblastoma are usually common in postmenopausal women. Some of the patterns of PASH, so this is the garden variety, like complex slit-like spaces that some spaces are not lined by cells, but some are lined by these flat spindle-shaped cells in the background of this dense hyalinized stroma. This is an example of fascicular PASH, where you see that the fibroblasts are arranged in small fascicles. That makes it difficult differentiating from actually the myofibroblastoma. So the other soft features to differentiate are myofibroblastoma is well circumscribed, but PASH can also be well circumscribed, but is this morphology in a myofibroblastoma would be throughout, unlike in PASH it might mostly be focal. Management of PASH. The pervasive thought for PASH tumor has been excision, but some authors also suggest like a close clinical surveillance and no excision if the lesion remains clinically and radiologically stable, and rebiopsy or excise if there are imaging changes. Inflammatory myofibroblastic tumor. It's extremely rare in the breast. Just like at any other site, it shows the nodular growth of myofibroblast-like cells in the background of lymphoplasmacytic infiltrate and lymphoid follicles. The 50% of them can be immunoreactive with ALK, and that makes much easier. Reactive spindle cell nodule. There are only a few publications that document its presence despite the frequent biopsy or surgical trauma to the breast. Usually they are seen after biopsying a papillary lesion and can range from 1 millimeter to like 9 millimeter. associated with previous FNA or core biopsy. It's composed of like an intersecting fascicles of plump spindle cells in a story-form pattern. But the other clues are, you can see hemosiderin-laden macrophages, foreign body giant cells, and scattered lymphoplasmacytic infiltrate, and a history of having a biopsy. They are positive for SMA and muscle-specific actin, but they are negative for pan-cytokeratin and high molecular weight cytokeratin, because always metaplastic carcinoma is always in the differential. Primary sarcomas of the breast are rare. The most common is angiosarcoma, followed by liposarcoma, then leiomyosarcoma, pleomorphic undifferentiated sarcoma. But with the increasing use of breast conserving approach, a lot of people, like women, are getting radiation, and that's causing increase in this post-radiation sarcomas. Most of these are pleomorphic sarcoma, unclassifiable, and also the cutaneous variant of angiosarcoma that appears after radiation. So those are increasing in incidence. But always think of metaplastic carcinoma before saying something as a primary sarcoma of a breast. Heterologous sarcomatous element in the phylloides, which can be anything like angiosarcoma or osteosarcoma, and metastasis. So in a brief about angiosarcoma, they can be primary or secondary. Primary, usually they occur in a younger woman, 30-ish, and there are no predisposing factors. It occurs in the breast parenchyma, and the secondary is usually like an older patient who have breast conserving surgery and received radiation, and that is most commonly a cutaneous angiosarcoma, unlike this one, which is like a breast parenchyma. Angiosarcoma can be very treacherous. They can be very bland, but you have to see like the anastomosing vascular channels that are dissecting through the mammary stroma. That's the important thing. So there is a lot of a talk about the grading of the angiosarcoma. So there are 3 grades: low, intermediate, and high. Usually low is when they are just a simple anastomosing vascular channels lined by atypical hyperchromatic cells, no endothelial tufting, no papillary formation, no solid areas or spindle cell foci. Mitosis is rare, and absence of the blood legs, or they call it stromal hemorrhage, and absence of necrosis. The intermediate grade is like tufting can be present, papillary formations can be focal, and the solid foci of spindle cells are absent, but they can be minimal, rare. And the mitosis is present in the papillary area, or they can be present in the solid spindle cell high-grade foci. Again, the blood legs and the necrosis is absent. In a high grade, there is a prominent tufting papillary formation. It's predominantly a solid component. Numerous mitosis, associated necrosis, and blood legs. So this is a low-power view. This is a high-power view of a low-grade angiosarc, which shows the anastomosing vascular channels, which are lined by cells, which are hyperchromatic and atypical, but not too ugly. There is some stromal extravasated RBCs here, and you don't see any papillary formations or increased mitosis or tufting. Unlike over here, which is an intermediate grade, you see a vascular differentiation. You also see a solid foci of spindle cells. This is a high grade, which is predominantly composed of solid areas and some necrosis and stromal hemorrhage. And here you can see poorly formed vascular structures that makes it much easier to differentiate it as an angiosarcoma. So Rosen talked a lot about the grade of angiosarcoma, how the grading is related to the survival. That was the concept before. But there are a lot of the studies recently that showed that the grade of angiosarcoma has no correlation with the likelihood of local recurrence, distant metastasis, and death. So it's the same like when angiosarcoma occurs at some other site, the survival doesn't depend on the grade. Treatment is total mastectomy. Axillary dissection is usually not indicated unless there is an obvious lymph node metastasis. And there is some talk about chemo and radiation. The other vascular lesions, and that are in the differential of more like a spindle cell lesions, and also vascular lesions which have spindle appearance, is an angiolipoma, which is it occurs all the time in the skin, but it can also occur in the breast. It is a subcutaneous single painful lesion, usually less than 2 centimeter. The cellularity can be variable. There is a cellular variant of angiolipoma. It has more spindle cells, and it can be a differential in angiosarc, because angiosarcs are also low grade. But the thing is, they have circumscribed margin. They lack this dissecting growth pattern of angiosarcoma. They are not atypical, and the characteristic presence of fibrin thrombi in the vessels differentiates angiolipoma. Hemangioma. Sinusoidal hemangiomas can occur in the breast, in the subacute. They are the variants of cavernous hemangiomas. There is also the Masson's tumor, or the intravascular papillary endothelial hyperplasia, that can occur in the breast. Perilobular hemangioma, like the name, it's not perilobular. It can be perilobular or interlobular. It's usually uncommon incidental finding. Microscopic is usually less than 2 millimeter, and it's clusters of congested capillary vessels. If there is a differential of hemangioma on the needle core, excision is recommended always to exclude angiosarcoma. Some of the things to keep in mind are hemangioma are rarely more than 2 centimeter, whereas angiosarcs are usually greater than 3 centimeter, and the Ki67 in hemangioma is less than 5%, and angio is usually more than 20%, even if it's a low grade. If a post-needle core imaging indicates that there is a complete excision and the clip is placed, follow-up mammogram may be acceptable. The other spindle cell neoplasms are solitary fibrous tumor of the breast. As I discussed, they are 34 positive and beta-catenin positive. So they are differential into the fibromatosis and myofibroblastoma, but then they are Desmin negative, and the fibromatosis would be not positive for 34. Nipple leiomyoma, as the name suggests, it occurs in from the smooth muscles of nipple. Excision is recommended. The leiomyomas that occur in the breast parenchyma occur from the blood vessel wall, and and the others are thought to be from the metaplasia of the myoepithelial cells in the breast parenchyma. DFSP, just like at any other body site, it occurs in the dermis of the breast or in the subacute, so it's above the facial planes. Leiomyosarcoma, MFH, malignant melanoma, and many metastatic cancers. Even the renal cell carcinoma, which has spindle cell morphology, can mimic the primary spindle cell lesion of the breast. The most important, malignant phylloides. Spindle cell sarcoma on the core biopsy may represent the stromal component of malignant phylloides. I won't be talking today a lot about the phylloides. It's a different category of fibroepithelial lesions. Just a brief about what they are. So fibroadenoma can be diagnosed on the core biopsy if the age is present, and it becomes much easier. The problem is between the cellular fibroadenomas and benign phylloides, especially on the needle core if the stroma is cellular. Then usually you would sign out it as a fibroepithelial lesion with increased stromal cellularity and recommend excision, and then the diagnosis will depend on the evaluation. Features that should prompt the concern for excision on the needle core: when the spindle cell lesion has irregular borders, or the FELs have irregular border, stromal atypia, or stromal mitosis. And always, whenever there is an atypical or malignant spindle cell lesion, the possibility of phylloides should be considered. In brief about metastasis, clinical history is the key. The most common entities that metastasize to the breast are malignant melanoma, lung, and ovary. There is a propensity for rhabdomyosarcoma in adolescents to metastasize to breast. So, some salient features of major spindle cell lesions of the breast. So the first is those with bland spindle cell morphology is a spindle cell carcinoma, which is a low-grade fibromatosis type, expression of cytokeratins and P63. Scars, you have a history of trauma, procedure, presence, and other changes associated with the biopsy site. A mammary fibromatosis, long fascicles, broad, nuclear beta-catenin staining. Nodular fasciitis, well circumscribed, rapidly growing lesion, has a tissue culture like fibroblast, myxoid stroma, and extravasated RBCs. PASH, collagenous stroma, separated by slit-like intra-anastomosing spaces, and these are lined by bland spindle cells. Myofibroblastoma is a fascicular growth separated by hyalinized bands of collagen or ropey collagen, and they are circumscribed. And the lesions with pleomorphic spindle cell morphology can be spindle cell carcinoma, which is high grade, expression of cytokeratin and p63. Malignant phylloides, the architecture and the presence of epithelial component. Angiosarcoma is the expression of CD31. And for other malignant spindle cell lesions, clinical history, what's the morphology, and the immunohistochemical findings. This is an algorithm. It's a busy slide, but I'll just go over it. So whenever there is a spindle cell lesion, look for the overall cellular composition, whether it's composed of only spindle cells or spindle cells with some other cell type. And this we will see in the next slide. Only spindle cells, look for cytomorphology if it's a bland or it's an atypical. The bland has its own morphology and differentials, and atypical has its own, but they can overlap. Then look at the growth pattern. How is the growth pattern? How are the tumor borders? How many mitosis? Is there any other coexisting cells or tissues? What's the clinico-radiologic appearance? Have a morphologic differential diagnosis. The IHCs should be targeted in this because, as you saw, there are a lot of pitfalls and overlap, and then arriving at final diagnosis if possible. Then mixed spindle and epithelial cell proliferation. So look for the epithelial component. If it's epithelial epithelioid or is actually in the form of glands, then the differential is narrow. Can be low-grade adenosquamous carcinoma. This is one of the descriptive classification of metaplastic carcinoma. Syringomatous adenoma is common in the nipple. Radial sclerosing lesions, mixed metaplastic and invasive carcinoma, not otherwise specified, and displaced glands in the needle tract. You would often see when there is a biopsy, these glands get displaced and they look like when the scar gets fibrosed, you feel like it's a residual or invasive carcinoma, which is just the glands that are displaced following the biopsy. Then when there are individual epithelial cells, look for the arrangement. Are these cells intimately admixed or they just separately coexist? Intimately admixed, the main differential is spindle cell carcinoma. This epithelial cell in the spindle cells can be anything: invasive carcinoma, ADH, DCIS, individual epithelial cells, or some of the cells you can see like they have the morphology transitioning between the epithelial and mesenchymal cells. If they exist, if the epithelial component exists separately, just a coexistence, most common is if they are fibroepithelial lesions, again mixed metaplastic invasive carcinomas, and the needle tract displaced epithelium. And in the same protocol of looking at the other characteristic of the tumor. So the key points are very small proportion of the breast lesions are spindle cell. If there is a previous history of breast cancer, there is a possibility that this is a post-radiation primary breast sarcoma. Most common are undifferentiated pleomorphic sarcomas and cutaneous angiosarcomas. There is a prior history of metaplastic carcinoma. The current lesion may represent a recurrence. This is especially a problem when there is a fibromatosis or low-grade metaplastic carcinoma. The diagnosis should be considered, the diagnosis of metaplastic carcinoma should always be considered in the differential diagnosis of any spindle cell lesion of the breast, and thus that must be excluded based on morphology, extensive grossing, looking for epithelial component, and also IHC, but negative IHC does not exclude the diagnosis. And the diagnosis of phylloides should also be always be considered, especially if only the stromal component is sampled, and careful scrutiny of epithelial elements is important. With the advent of needle core biopsy, the accurate diagnosis is challenging and the definite categorization may be difficult. So it's good to have a cautious approach on the needle course. When in doubt, recommend excision and diagnose it as a spindle cell lesion, either of high grade or low grade, and then excision recommended and defer to final excision. IHC is helpful, but it requires correlation with the clinical and morphologic findings, and there can be pitfall, like if there is a focal positivity, it can be missed, and if you have again a needle core, it may not have that area, and non-specific staining like giant cells, etc. Clinical and radiologic information is required. These are my references. Thanks to Dr. Klein. And any questions?
Thank you, Prachi. Very comprehensive encyclopedic presentation. I must say that some of the last slides you showed were my favorite, when you showed that algorithm and highlighting the fact that reaching the correct diagnosis comes through multiple steps, incorporating clinical, incorporating radiology, morphology, and after committing to a certain differential diagnosis, then IHC comes at the very end. In both algorithms we showed, IHC was the very last step, and we only reached the stage of ordering IHC after committing to a diagnosis or a differential diagnosis. So that was very clever from you. My question to you is, you have been with us for how many years? For many years. In your experience, how many of these lesions have you seen? You have seen metaplastic carcinomas. I'm sure you have seen PASH, and you have seen fibromatosis and Adenomyoepithelioma. What would be your impression about the prevalence of these lesions here in our practice?
They're very rare, I must say. Very rare. But I mean, I don't know. I have seen a lot of these spindle cell, especially the metaplastic carcinomas, at least 2 or 3. Like they were like called as something else. Like clearly, like even Dr. Klein told me she had a case which just stained like a Leiomyosarcoma, and was called Leiomyosarcoma until the final excision, and then there was just a very small focus of epithelial. So I still think even there are this lot of other differentials. What we commonly still see is the phylloides, stromal overgrowth, and the metaplastic. More than even what I have seen is more than metaplastic, the stromal overgrowth of phylloides. I just had a case. I looked with Jim has the continuing care, so it was a needle core, and that was called borderline. It was from outside. It was referred to some expert consultant. It was still called borderline. There was extensive stromal overgrowth. That's one of the main criteria for phylloides, to call it as a malignant phylloides. But it was still called borderline because it didn't fulfill any other criteria. There was no any significant atypia, no mitosis, nothing that recurred. She underwent mastectomy. She had like 3 or 4 procedures. And now she's here and she has a chest wall recurrence. And now they say that it's a malignant because it's behaving like a malignant. So I don't think immunostains would help. And that case had a P63 positivity. So we were confusing, did they misdiagnose as a metaplastic? But then there is this new paper from Johns Hopkins which talks a lot about how P63 and P40 cytokeratin, everything can be positive in malignant phylloides. So even the stains are not sure about any diagnosis.
I'm sure you've seen the literature is full of clues and methods for diagnosis. As I was listening to your discussion, and it's very clever, I think you have an opportunity here to study something, I'm not sure if it has been studied before, which is the language used in reporting biopsies and how that translated to patient management. And you can make that correlation. If you can collect 500, 600 biopsies and look at the phrases the pathologists used in their diagnosis and how that translated to the next step in management, I think you can inform the literature Because at the end you mentioned something about being safe and accurate, and that's obviously that's what we do. Being safe in terms of diagnosis, being safe in terms of immunohistochemistry, but sometimes we mess up by just saying the wrong word or saying the word that will be misunderstood. So that's a very nice gray zone to study the actual verbatim and the language that pathologists use and how that can be safe or otherwise.
Okay. The questions?
Just a comment. That was a very nice presentation. That's a lot of information. I think for someone who's not a breast pathologist, it's kind of probably overwhelming. For me, it was great.
It's okay.
But just like from a day-to-day practice, I think you're absolutely correct. These are a small percentage of breast lesions, but they produce a high percentage of pain from the pathologist because they're just really difficult. There's a chance for underdiagnosis to call something a benign lesion that's actually malignant. Every kind of breast pathologist will tell you the horror story of the Fibromatosis-like Metaplastic carcinoma that was missed. And then there's also an unfortunate potential for overdiagnosis. So one of the first cases I saw in fellowship was a mastectomy, where the core biopsy had been diagnosed as a carcinoma. It was actually an Adenomyoepithelioma. So that's another terrible scenario that you never want to see. You just you have to be careful. If you don't know, and we always want to kind of give the most information we can. If you don't have that much, you have to be vague in your core biopsy.
Thank you.